Hello, everyone, and Happy New Year. Thank you very much for attending. My name is Matt Callison.
Hi, thanks for attending. I'm Brian Lau.
We're from AcuSport Education and the Sports Medicine Acupuncture Certification Program. Thank you to the American Acupuncture Council for having us. We have a sports acupuncture webinar. It's always really fun to be able to do this once a month or every other month. This particular one, we've got more information for you. We had such a good time last month with Ian Armstrong, who's the teacher of the Postural Assessment and Corrective Exercise class in the SMAC program. Brian and myself had a great time discussing elevated ilium and its contribution to medial knee pain, and explored the different sinew channels and different acupuncture points and exercises that can be used to help to correct this. And Brian, I was thinking it'd be great to be able to actually do something similar, looking at an elevated ilium and its contribution to a superior shift of the scapula or an elevated ilium, and the injuries that that can cause, and some exercises that would be useful to apply after the acupuncturist acupuncture treatment. So unfortunately, though, Ian had some commitments. He wouldn't be able to join us, so Brian and I are going to go ahead and take this over. Brian, what do you think about us going to the intro slide? And if you have any words or so you want to share?
No. Basically, I guess just a small thing is that elevated ilium could cause a whole ton of potential pain patterns, of low back pain, hip pain, a whole bunch of them. Last time we chose to see how it can relate to the lower extremities, especially the knee, for medial knee pain. So it's just an example to see how to start prescribing exercises, how to add them into the full comprehensive treatment. So as Matt said, this time we're just doing the same thing, elevated ilium, but its relationship to the shoulder girdle, and then shoulder dysfunction and other upper extremity type problems. But we'll give some more specific examples, but just keep in mind that there could be a whole ton of different dysfunctions that could come from just one simple thing like an elevated ilium.
All right, well, let's go to the next slide. I think that's a good segue for, you want to go ahead and start with this one?
Yeah, so with this image, again, we're focusing in on a postural disparity. We picked an elevated ilium because it's clinically relevant. It's very common. You see it a lot in clinic, and you see both how it can relate, like I said, to local pain patterns like low back pain, et cetera, but how it really becomes, since so much weight transfers through the hip, it's really one of the key structures that determines symmetry for a lot of the rest of the body. So if you can balance the pelvis, that goes a long way in and of itself to balance the shoulder girdle, to balance the lower extremity, knee position, foot position, et cetera. So it's not the only thing, but it's really a big thing. So we'll look at its relationship to the shoulder girdle today and give some exercise review, refer back to last time's podcast where we looked at some exercises for the ilium itself, and then we'll look at some exercises for shoulder girdle, but then how to combine those with acupuncture treatments. So in this image, you see this gentleman on the right. There's a elevated, and you can kind of see the schematic image. You can see that he has an elevated ilium on the left. So you follow a line from the top of each iliac crest. You can see an elevated ilium on the left. We'll look at some other ways you can measure it in a second. Then look at, just for now, the relationship. This is the most common way that it would present, is that you'd have a balancing, in the girdle of the shoulders, a shoulder girdle balance, where it's going to start to compensate to that elevated ilium. And in this case, you see that elevated scapula on the right. And that's probably the most common way that this would present. It could do it differently, but this is definitely the most common. Opposite elevated scapula, or a superior shift, you might call that.
Good. I just want to emphasize as well that Brian was talking about balancing the elevated ilium or any kind of ilium type of postural disparities. I mean, the reason why you can see that it's going to be the middle section of the skeleton. It's going to affect what's happening above and below, in addition to housing the dantian. And the kidneys being just above. So by balancing that aspect, it helps all kinds of different things the acupuncturist can be treating, from pelvic floor dysfunction, lower jiao disharmony, OBGYN, middle jiao disharmony. So looking and balancing of the musculoskeletal systems, not just for orthopedic, it's also for helping the zong fu. So that's That's great. And this is what we emphasize in the SMAC program, is trying to be able to get that elevated ilium or any kind of postural disparities in the pelvis to go ahead and treat that first, which I'm sure a lot of practitioners will actually go for that as well.
Yeah.
Anything else, Brian, before we go to the next slide?
Yeah, we're going to be zeroing in a second more on the shoulder and scapular position, but in this particular model, you can also really see the change in the position of the neck. And I'll just give you a very simple way to see it. If you could picture that ilium elevated, I think I'm mirror imaged here. My right hand's up, but I'm trying to make it look like my left hand to kind of match this model. If the ilium's elevated on the left, the person's not going to stand in such a way that they're leaning, leaning Tower of Pisa over on that side and everything's pointing, to the left. They're going to find some place to compensate. That some place could be multiple places. It could be in the spine, which you see a little bit of in this model. It can be in the shoulder girdle. It can be in the neck. They're going to find some way to get their eye and their head and ear position, the equilibrium of the body a little bit more balanced. So if the shoulder girdles are really fixed, maybe they're going to find a way to do that all in the neck. But the common one, the very frequent thing you see, at least that's going to be part of this dynamic, is the contralateral shoulder being higher and the compared to the hip. So left hip, right shoulder, right hip, left shoulder.
Great. As you can see that image on the right, the patient has an elevated ilium on the left, and it looks like there is elevation on the right as well. He does have a little lateral tilt to the right with the scapula, with the head that Brian was just talking about. So one of the muscles that we're going to the only muscle that we're talking about, well, primary muscle that we're going to be talking about in this webinar, the levator scapula. So can you see where the levator scapula attaches on the image on the left, the superior medial border of the scapula, close to small intestine 13. And then its other attachment is going to be the transverse process of C1, C2, C3, C4. So the superior shift of the scapula, and you've got a shortening of that levator scapula, small intestine sinew channel that we're going to get into a little bit more in this webinar. In a locked short position, it's pulling the neck to the lateral side. So a multitude of injuries can be occurring from this that we're going to be getting into.
All right.
Well, then let's go to the next slide. It's a quick review. This is what we talked about last month about measuring the ilium. So you can see the middle image. The hands are coming in on the side, on the lateral side, and the fingers are placed at a level line right on top of that ilium. Gives you an idea of which side is going to be elevated.
Mm-hmm. And you would be right behind the person, but that doesn't work for the camera position so well.
Go ahead, Brian, you can finish.
No, I just wanted to say that just for people to know that that if you're measuring that, you'd be right behind the person, but Matt's moved to the side to be able to see where his hands are. So just that heads up. Yeah,
true. And then functional anatomy from OHS, overhead squat from the National Academy of Sports Medicine, looking also at what happens with an elevated ilium is usually an asymmetrical hip shift. And there's a whole slew of sinew channel imbalances that occurs with this. And once we see this kind of posture, we're automatically thinking of different acupuncture points that we can treat for locally adjacent and distal of the primary channels and the sinew channels, in addition to what this kind of posture is going to be doing to the organs. Mm-hmm. All right, well, let's go to the next slide, please. All right, so here you've got elevated scapula, or also called the superior shift of the scapula, and it's going to be associated with a lock short levator scapula that we discussed earlier, which you see here on this individual's left side. This individual has an elevated ilium on the right. Often, like Brian was saying, it's probably most of the times, but not all the time, there's never and always, is that the opposing side will have a superior shift of the scapula. Sometimes you'll see a superior shift of the scapula on the same side of an elevated ilium, but what we're going to be discussing here will still apply. Mm-hmm. All right, so this posture can lead to many different muscle and channel imbalances that we're going to be discussing just a few of them. Some of the injuries that can happen with this will be rotator cuff tendinopathy, the rhomboid minor constraint, thoracic outlet syndrome, and there's more. Brian, you want to say anything before we go to the next slide?
Well, I think we also have in the slide, or is this the next one? Yeah, the downwardly rotated scapular position. And I think we have it a little bit more on the next slide, so we can go over it a bit more there. But if you look at the scapula in this position, the left side, if you look at the glenoid cavity, so I have a little scapula here. So I think this will look more like my left side. If you're looking through the rib cage at the front surface of the scapula, the glenoid fossa would go up. That would be upward rotation. This patient has more of a downward rotation of the scapula. And that's pretty typical when the levator scapula is shortened. We'll talk about this again in the next slide, but that'll play into some of the discussions we have coming up in a few slides also.
Okay, so next, please. All right, so this video is not playing. Maybe if you click on it, it'll play. Let's see. Okay, so it's not playing, unfortunately. Well, that's what happens with technology sometimes. So let's just walk through this.
No, I think it's coming.
Is it? Oh.
Yeah, I can see him working on it. Looks good. There it goes.
Ah, you got it. Right on. Thank you. Okay, so one of the actions of the levator scapula, as the name suggests, it's going to elevate the scapula. Now, what this is not showing is that you do have elevation in the scapula, but if you look at the origin and insertion, or the distal and proximal attachments, it will also downwardly rotate that scapula, if you will. Brian, can you show downward rotation again on your scapula?
Yeah, so tell me, Matt, you can tell me if this is the case. This is the right scapula, but I think since we're on, I think everything's mirror image. I'm trying to make it look like the same. So does that look like the right side?
Yes, but can you do us a favor? Can you go ahead and keep it in front of you, because it blends.
Yeah.
You can't see very well with the white background.
Yeah, okay.
That looks really great. We're going to have to raise it up a little bit, at least on my window.
So now.
Okay, good. Yeah.
So you're seeing through my rib cage to the front surface of the scapula. Levator scapula would be attaching here to C1, 2, 3, and 4 transverse processes, a muscle of the small intestine sinew channel, and it would lift or elevate the scapula. And at the same time, it would, mirror imaging is hard. It would bring the side of the neck down to that side too. It would side bend the head. But we're talking mainly about the scapular position, so elevating the scapula.
Okay. That's great. So let's go to the next slide, please. And I think we're going to talk a little bit more about the rotation.
Yeah, and this one will look at the downward rotation of the scapula.
So there's upward rotation, downward. So when you see green of that levator scapula, that's when it's shortening, concentric contraction. It's active. And the red's going to be a lengthening contraction. So green's going to be downward rotation, and then you've got your upward rotation. So in a locked, short levator scapula, you can see how it would have a propensity to be stuck in a downward rotation, which will then, when you're raising the arm into shoulder abduction, like the scapulohumeral rhythm, that image that's on the right there, the greater tubercle, a big prominence on the humerus, or the supraspinatus and infraspinatus, and on the opposite side, the bicipital longhead tendon, can come up and hit that acromion and cause a tendinopathy and impingement. There's one more image I think that will also be able to help with this. Can we go to the next slide?
Yeah, there we go.
Yeah, so then this would be when the levator scapula has been placing that scapula into a downward rotation. As the arm goes into abduction, then the propensity for that greater tubercle to hit that acromion is much, much higher, leading to injuries that we were talking about. So all of this gives us actually different protocols to be able to treat this. But for right now, levator scapula is going to be a big one to do. And we will talk about exercises here in a second. Brian, do you want to add anything to this?
Yeah, so the main thing we're looking at, though, is very, I guess, biomechanical. We're looking at particular muscles, in this case, the levator scapula, and how it's going to elevate the scapula and how it's going to tend to hold the scapula into that downward rotation. If it's shortened, it's going to prevent the scapula from being able to follow the arm position, right? That would be normal movement to help keep that space between the acromion and the head of the humerus open, so it doesn't pinch structures like the supraspinatus tendon, the biceps tendon. So you'd want the scapula to be able to come upward into upward rotation as you're going into abduction. But if it's kind of held too firmly in place by an over tight levator scapula and maybe some other structures, then it's going to prevent that scapula from moving, and then the arm's going to bump into the acromion, and that can lead to a lot of different pain patterns of the shoulder. So that's a very biomechanical view. That's great. That's great information in and of itself. But then we have to remember that we have this whole, really beautiful, intricate channel system. And the levator scapula, the muscle we're kind of looking at in this case, is a muscle of the small intestine sinew channel. So we can needle it at the motor point, but we might include small intestine channel points to help contribute to a more thorough therapeutic outcome. We started with the elevated ilium, and the quadratus lumborum is a big muscle that's involved with the elevated ilium, as are the adductors, the thigh and hip adductors. Those are muscles of the liver sinew channel. So we have this midday, midnight channel relationship that's involved with maybe this local problem. We have a very more comprehensive channel perspective that we can look at and start including points to directly affect the elevated ilium, like the quadratus lumborum, like adductor longus, liver channel points, maybe something like liver 5, in combination with small intestine channel points and more local needling at the small intestine channel sinews. And then we can add other points in our acupuncture treatment based on the specific injury and other things we're finding. And, is this person blood deficient or yin deficient or something like that? So this is starting to paint a more of a comprehensive picture that we're looking at.
That's something we find a lot in our own clinical practice, is looking at the midday, midnight relationship between the liver channel and the small intestine channel, especially when there's a shoulder abduction problem, such as what we're seeing in this slide. Elevated ilium and shoulder abduction problem is pretty darn common. You'll see that a lot in the clinic. If you would, when you're looking at the scapula, you guys, take a look at that superior medial border of the scapula. That's where the levator scapula is going to be attaching, where many people have that fibrotic tension in there that many of us will go ahead and needle right through that. That levator scapula, as we talked about before, is going to be attaching to the C1 through C4 transverse processes attached. That then it goes down and it travels to the superior medial border. Like I said, it blends in seamlessly with the supraspinatus muscle that's located in the supraspinous fossa. In this particular image, if you go distal where large intestine 16 would be, then you've got large intestine 15 just on the other side of the acromion. Hopefully you guys are following along with this. Large intestine 15 is where the supraspinatus tendon is going to be attaching. It's usually about a quarter of an inch to probably 5/8 of an inch wide, blending into the capsule and attaching right onto the greater tubercle. Then from there, you've got your triceps, part of the small intestine sinew channel, and also going all the way down to flexor carpi ulnaris, which we talk a lot about. The flexor carpi ulnaris motor point is a magical, I'm going to use the word magical because it is, empirical point that will soften the distal attachment of the levator scapula 99% of the time. When you do actually get that flexor carpi ulnaris motor point right, it will soften that attachment site pretty dramatically. And this is something that we've been teaching in the program for probably about 10 years or so. It's a really nice distal point to use with levator scapula shortening and pain at that proximal attachment. Brian, you want to say anything else before we go on?
Oh, no, that's good.
So I think we're actually kind of moving right into exercises now. So the next slide, please. So last month, these were some exercises, or a exercise, different levels of the figure 4 crossover. That's working quite a bit on the piriformis. This exercise and a lot of the exercises that we use are based on Pete Egoscue's work. What we've done is we've actually looked at the different angles as far as the functional anatomy of the sinew channels, and we've modified his work, which actually happens quite a bit with people's methods and techniques, is that other people have good ideas about it and they just kind of form it in a slightly different way. But we did want to give a shout out to Pete Egoscue for his miraculous work in exercise prescription, what he's done over the years. So again, with this is what we've done for the elevated ilium 1 exercise, and that's going to be discussed a lot further in last month's podcasts. And also we have a blog about it as well on the sportsmedicineacupuncture.com website. Let's go to the next slide and we'll talk about exercises that we can use for a levator scapula or a superior shift of the scapula. This exercise for elbow press is an exceptional exercise. Brian, do you want to start with that or do you want me to go?
I can start, and there's a little bit of a dialogue. So if you need to go back and look at it after the recording, it'll give a step-by-step. But the idea is you're giving a little bit of a press of the elbows into the floor. But more importantly is you're bringing the shoulder blades, the scapula together. So towards the midline and down. So, in this case, levator scapula is going to tend to pull. It might be on one side, but pull that scapula up. So you're depressing using lower traps and using the rhomboids and middle traps to bring the shoulder blades together and down. So it's the same time opening the chest and dropping the shoulder blades. I don't know if you wanted to add anything else about it, Matt?
Yeah, I was just looking at the image and how handsome Ian is. Enjoy in this exercise, it's going to be focused on what the scapula is doing, and then 10% of it is going to actually be pressing into the floor. So this is a strong scapular stabilization exercise that works great after needling or doing acupuncture to the levator scapula, pectoralis minor, small intestine sinew channel, a number of different points that we could use with this one. This is a simple exercise and kind of a triple star exercise that you can use even to advanced people because it does require quite a bit of concentration to really get those scapulas to really form down and lock in. Then the next exercise actually complements
Can we stay there for just a second?
Yeah.
This is a short format, so we can't go into it too much, but if you go back at some point, if you want to look at the recording and look at the movements of the scapula, we were talking about levator scapula, but pec minor, muscle of the lung sinew channel, would be involved in a lot of these too, because it's the antagonist relationship with levator scapula, because it's going to depress the scapula. So if it's really short, maybe the levator scapula has to fight against it. But it also works with the levator scapula and downward rotation of the scap. So I like this exercise in this case also because of that opening and lengthening of the pec minor and kind of normalizing of tension of that, which is kind of not the direct channel we're looking at. We're looking at the small intestine sinew channel, but how maybe the lung sinew channel is coming in and relating to this picture. This exercise would be given after the acupuncture treatment. So maybe we've needled the pec minor on that side to make it more accessible for the patient right away. Their body's ready for the exercise, kind of primed because we've reduced tension in the pec minor and allowing them to more effortlessly do this exercise.
Mm-hmm. Yeah, cool. And Brian, I'm sure we've kind of rushed with this. There's a lot of things that we really didn't talk about, like the lower trapezius being an antagonist to the levator scapula, elevation and depression, and the lower trapezius being large intestine sinew channel. So it's nice to be able to see that internal and externally related channels of the lung, pectoralis minor, lower trapezius, large intestine being called into place. What does that mean? Well, in our mind, if you would needle the motor points of each one of those, you're already signaling those two myofascial sinew channels. So therefore, if you complement that signal with more acupuncture points adjacent and distal, it has to have an effect on those particular muscles because it's a signaling system that we use in acupuncture. Brian, you want to say anything about that?
No, that's good.
All right, cool. All right, so again, this elbow press is a great exercise to use as a preliminary exercise. So what about the next exercise, please? Yeah, okay. This is one of our favorites. I would say triple star, maybe even quadruple star. This is an exercise that takes a lot of concentration, and how we modified it a bit from how it was originally taught is we are increasing or decreasing the thoracic flexion. So we're increasing thoracic extension. Let's walk through that. So the first position, the person's going to have their knuckles on Tai Yang, usually the middle finger there. They're going to keep the wrists straight. The elbows are going to be out, as you can see. The knees are going to be at 90 degrees and the hips are going to be at 90 degrees. We ask the person to go ahead and bring their elbows together toward the ceiling, keeping their fingers right at Tai Yang. All right, so by them doing that, you've got scapular protraction. Then we ask the patient to begin the movement back down, bring their elbows back down, leading with the rhomboids, leading with that medial border of the scapula, and start to bring them together. All right, so you've got protraction and retraction. This exercise is really getting the agonist and the antagonist of those muscle groups working together. Now the emphasis, once the patient is able to do this successfully, now we actually increase it a little bit. We ask the patient to bring their elbows together when they're going up to the ceiling, but above their nose. So what I'll do is I'll actually put my finger right above their nose and try to have the patient bring their elbows up toward the nose, which is very, very difficult. In order to do that, you really need quite a bit of thoracic extension, which is a wonderful thing to do when somebody has thoracic flexion in those upper vertebrae, right? For example, in upper cross syndrome, and that head is forward. So this is a great exercise for that. It's gonna work the levator scapula quite a bit. A lot of the scapula stabilizers, and it's definitely one of our favorites to use. This is also something that you may want to use with somebody who has upper jiao problems, for example, asthma or any kind of lung problems after COVID, maybe COPD, because how it's working the front mu and the back shu points and getting those muscles to be able to work in coordination, it's going to work the channels as well and coordinate the channels.
Mm-hmm. Yeah, we had a question regarding this one, if somebody had a difficult time lying on the floor. So we cover stuff like this a lot in the program, where we have multiple amounts of different exercises that can be done that would be maybe a simpler exercise if it's somebody who has a difficult time of getting on the floor because maybe they're not very conditioned. So I might go with a more simplistic exercise, but there is an actual variation of this exercise that's a little different, but it's the same concept that can be done seated with a strap. It's a little bit more isometric, where you're pushing out against the strap and lifting and doing some similar focus, but that would be adequate for somebody also if that was if they were ready for that exercise, they could do the seated. Maybe they can't get on the floor because they have a shoulder injury and they can't support themselves. So you could definitely adapt this one to a seated position. Or you could just give them a more simple exercise.
Yeah, cool. Good one. All right, so then what we talked about last time was using acupuncture as assessment, but also using intradermal needles for increasing range of motion or decreasing the amount of pain during an exercise. For example, if somebody's having a hard time proprioceptively trying to figure out how to do this exercise, or they may be limited in their range of motion, kind of stuck, or perhaps they're feeling a little bit slight pain or minimal pain with it, but it's inhibiting them from doing the exercise. This is where intradermal needles on extraordinary vessel points, but also you can use channel points too. Extraordinary vessel points works pretty darn amazing. This is something that we teach in the SMAC program. For those of you that have the sports medicine acupuncture textbook, let me think, it's in chapter 4 toward the end, with exercise before treatment and exercise after treatment using intradermal needles. So it's in that section, chapter 4. So what you're about to see is a video of the SMAC program and the postural assessment and corrective exercise. And there is a student there that's having difficulty with actually doing this exercise. And so we're applying intradermal needles based on what motion was the most painful or difficult. Okay, so let's look at the next slide, the movie. Now, we know that you can't hear. Let's just read.
Scapula, so now I'm starting to go, and right when I hit this point, I feel like I just get stuck. I can't bring them anymore. Like, I have no strength or flexibility no more.
Wow.
Really? I am not. That is so wicked.
Keep going.
Okay.
Wow.
That was a good one.
That's awesome.
I still love her expression. It's always so fun. Yeah, so we can probably advance it to the next slide. We use Pinex needles from Sarin, and you can get those from Lhasa OMS. The 0.20 millimeters by 1.2 millimeter. That's some of the best ones because it's large enough to be able to create a sensation, but not large enough to be uncomfortable during movement. So those seem to work out pretty well with us.
Mm-hmm. And you can send them home with, I mean, keep them in for the patient for a few days while they're performing the exercises to assist, to keep that stimulation going.
Yeah, cool. Well, great. I think well, I mean, we could talk about this for hours, but we only have 30 minutes and we've already gone 6 minutes over that. So thanks very much, you guys. And I think we're going to be scheduled again in February or March. Hopefully we'll see you again then.
Yeah, and then next week, Sam Collins is on.
Sam's going to be there. Oh, awesome.
Yeah.
If you have Sam talk, he's hilarious. He's really quite sharp as a tack, and he's fun to listen to. So thank you very much to the American Acupuncture Council. Brian, you're awesome as always. And thanks, you guys. And hopefully we'll be connecting again soon.
All right, great. Thanks, everyone.
Okay, bye.